Dr. Pang Hong Wu from Ng Teng Fong General Hospital, Singapore, part of the National University Health System. I would like to thank the organizing committee of MISSABSCON, Prof. Pramod and Prof. Vishal for the invitation to share my thoughts on complications of endoscopic spine surgery, all that glitters not gold. This is my disclosure. Some of them are relevant to this topic. I practice in Jurong Health Campus in the western part of Singapore. The majority of my cases are endoscopic spine surgery. I do both the uniportal and biportal endoscopic spine surgery. Uniportal system work around by docking and work around the dock area with some exceptions. The main uniportal designs and dimensions varies between transforaminal to interlaminar to stenosis as well as vibroscope to allow maximum performance and yet achieve minimal soft tissue disruption. The key in uniportal surgery is accurate docking and working around the dock area of anatomy, while in the bipolar endoscopic spine surgery focus is on floating around the dock region and separates out the viewing and the working portal. Common complications encountered as described in one of these papers that I was involved in is nerve root dysesthesia, hematoma, either within epidural space or outside epidural space, a dural tear and incomplete decompression or recurrences. Uncommon but important is neurological deficit, and of course in endoscopic fusion we have scope-related and implant-related complications. In the limited time, we'd like to share some of the more common complications such as hematoma. Hematoma and hemostasis are important aspects of preventing complications. The bleeding sources can be the cancellous bone, the epidural vessel next to the disc as well as around the nerve roots. And then in the extraforaminal disc region, also radicular artery next to the exiting nerve roots. We have options of radiofrequency ablation, gel foam packing, and flow seal or increasing pressure temporarily. I describe a case of outside epidural space hematoma. This is a patient with right transforaminal endoscopic lumbar discectomy and subsequently also right unilateral laminotomy bilateral decompression of L3-4. A patient who has a 67-year-old previous fusion with end-stage renal failure and on hemodialysis. He has associated shooting pain, sciatica, right worse than left, for a 3 week duration associated with weakness and significant straight back raise of only 40 degrees. And then you can see that basically you have adjacent segment degeneration and prolapse disc with stenosis, with L3-4 disc extrusion appears to be causing severe spinal canal lateral recess stenosis in the lower spinal cord, compressing on the chorda. So we perform a transforaminal endoscopy first. It's a remarkable surgery, and you can see that we have removed the disc successfully. We use a mobile outside-in technique on the right side. You can see that we have dock on the top. 3 o'clock position is that of the L3, and the 9 o'clock position is the L4. I'm standing on the right side, and you can see that there's some, at the end of the discectomy, there's some bleeding, but the retractor tube kind of retracted it. And when I was pulling out my scope, I wasn't seeing significant bleeding. Hence, I didn't use flow seal when I pulled out the scope. And then I went on to perform an uneventful unilateral laminotomy bilateral decompression. However, when I close the skin, I find that there's some significant bleeding from the transforaminal wound. However, I managed to close the skin and the patient's vital signs were stable. However, he developed a flank pain and anemia on the blood test and found that he has in the CT angiogram that he has a right abdominal retroperitoneal hematoma of significant size. And then he was hypotensive and he was transferred to ICU. He fortunately was treated conservatively with corset and was weaned off by vasopressor, and a day later he was transfused a few pints of blood, about 6 pints in total, but there was no need for further evacuation. I did a literature background research and found that most of the patients who had this retroperitoneal hematoma are treated conservatively. In epidural hematoma, we did our own series with Professor Hyo-sung Kim. We found that there's about 10% in all patients who have LE-ULBD stenosis score. 10% of them may have fluid hematoma, although only 27% may have fluid hematoma, or only 10% of them are symptomatic with pain score more than 5. Fortunately, none of them have neurological deficits, and they are associated with higher post-op pain score as well as ODI. Fortunately for them, most of them are treated conservatively, and the hematoma resolved with 6 weeks to 3 months duration, and patients did well eventually. This is a picture of the hematoma. This is post-op day 1. You can see that there's significant epidural hematoma with chorda compression. Fortunately, no neurology. Patient presented with back pain and radicular pain. There's an option of hematoma evacuation, but the patient opted not to do that. And subsequently, in the 6 weeks MRI, there's resolution of hematoma, and in the 3 months MRI, the hematoma is completely absorbed. However, of course, this is a significant complications and it should be counseled accordingly. And post-operative dysesthesia does happen in spinal endoscopy, and we find that in this publication that we had, most of the time is due to the compression of the exiting nerve roots as we do transforaminal endoscopic surgery. In our series, we found that the interlaminar approach probably has a better decreased rate of post-operative dysesthesia, and it should be considered in patients who have foraminal and extraforaminal disc compression. In the post-operative dysesthesia, there are 3 grades, and then we find that the second grade of dorsal root ganglion retraction dysesthesia is the most common group. They may not have motor deficits, but they have dysesthetic pain and burning sensation. And in the grade 3, of course, there will be motor and sensory deficit. Fortunately, it's usually not permanent in grade 2 and maybe permanent in grade 3. We find that the contralateral approach has this decreased rate of post-operative dysesthesia. Main of the reason is that we do not really squeeze the exiting nerve root when we do this approach. This is a video showing how we perform the contralateral approach. We find the exiting nerve roots, which is adjacent to the superior articular process. We change to a smaller endoscope with the working channel while we are doing that. And then now we can see a superior articular process on the contralateral side. We can see the exiting nerve roots. And then we drill the superior articular process of the contralateral side and expose the disc space. And then we check the exiting nerve root is fully decompressed, then perform a discectomy in the foraminal region, taking care not to injure the exiting nerve root or to compress on it. So you can see we are actually in full view of the exiting nerve root while working underneath it. We are working from the right side towards the left. And you can see that we take out this disc successfully under the exiting nerve root. And this is the final view. Because of that, we are able to decompress without causing post-operative dysesthesia. Recurrence is a significant problem. I think inadequate decompression as well. This is a 35-year-old lady with extraforaminal disc. I think it was referred from another hospital. The patient underwent TLD by another surgeon. I was observing his talking. I think he was talking too medially, and we saw on the foraminal extraforaminal disc. So post-op pain is not really better. Despite the surgery, she still have pain in the L4 region. With a pain score of 5 to 6, and there's a residual disc in the extraforaminal region as well, and the foraminal stenosis is still significant. We tried conservative treatment, she didn't get better, and hence she opted for endoscopic revision. I chose the bipolar approach because there may be a less likelihood of exiting nerve root dysesthesia in a floating approach rather than using a transforaminal approach. And I find that using larger chisels as well as drill in bipolar floating technique setting allow us to have a better discectomy option as a revision setting. So we can see that this is talking. We talk about 2 to 3 cm lateral to the pedicle, and we use the viewing portal and the working portal separately. And then we can see that as we progress, we move from the extraforaminal to the extraforaminal to the lateral recess with our scope. So this is a video showing how it's done in the revision bipolar setting. And fast forward a bit, and then you can see that with the floating technique, we can describe pretty well, and you can see the exiting nerve root. It helps in preventing exiting nerve root dysesthesia. And then we subsequently identify the superior articular process, and we perform chiseling, drilling, and decompression of the superior articular process to decompress the foraminal stenosis. We only take out the ventral aspect of the superior articular process as abutting the nerve roots, hence that prevents subsequent spondylolisthesis because the dorsal aspect of the superior articular process is still supportive, and we hope that prevent the instability. Now that we have done that foraminal decompression, we identify the exiting nerve roots and the disc that's adjacent to it causing compression. I think the initial surgery did not address the exiting extraforaminal disc, and hence we perform this bipolar surgery to further decompress the extraforaminal disc. You can see that we managed to decompress the exiting nerve roots and move on to identify the traversing nerve root and remove this in the extraforaminal and foraminal region. Finally, the nerve root is fully decompressed, and the patient did well post-op. With a 2 small wound and disc removed, the patient, she was very happy after the operation, and the pain has finally resolved. I follow her up for a year now, and she's still doing well and back to kindergarten working as a teacher. Overall, the incidence of reoperation rate ranges from 16 to 40% in the open, and also about 16 to 10% after endoscopy. 10 years after post-op. So there's a similar reoperation rate. We quote typically about 10%. Partly due to degeneration and axial loading, and of course, various multiple factor. I think when we do transforaminal endoscopy, it's important to do a half-half view, meaning we can see the exiting nerve root and traversing nerve root well, and also assess the volume of the disc before we complete the surgery. Dural tear is an important complications, and it's more common in stenosis scope than the interlaminar or transforaminal scope. It can affect the outcome of the surgery as well as quality of life. In our series that we published, we have classified the various type of dural tear. I think the most common cause is actually a teresm punch or tissue dissector, sometimes as well as that of the drill. You can see that in this setting, we have nerve roots that is exposed, and then there is a CSF that is detected in the post-op MRI. So in this setting, we can use the patch blocking technique. First, we apply your gel foam and then the tackle seal on top, and subsequently a larger gel foam and a tackle seal. So this is how we done. Oh, then we found that there's exiting nerve roots. There's a dural tear, and you can see the nerve root kind of herniating out. So we have to patch it, and then first we put in a gel foam, and then subsequently we put in a larger gel foam and the tackle seal to seal up the defect. Okay, and then we take another larger tackle seal to completely seal off the defect tackle seal. There's an adherent property, and it is very good in preventing the gel foam to come out in this patch blocking technique. Stages of learning curve as well, more than the late stages. Complications are fortunately usually minor, but like all spine surgery can be catastrophic. I think a good program of fellowship, workshop, as well as observership, constant engagement of experts to handle complications to ensure that we provide safe surgery for our patients. Just a final advertisement, the guest editor of the Medicine Journal will be inviting a special issue of recent advances in endoscopic spine surgery. Please, we have extended the submission to April of 2023. Please submit to us if you have articles that are related to endoscopic surgery. Thank you.